This is the video of Robotic Heller's Cardiomyotomy with Toupet Fundoplication. I have used CMR Versius surgical robot in this case. This is a CT picture. You can see the dilated esophagus with mild tortuous on the right side, and it is turned to left side also. This is a barium swallow, shows dilated esophagus with tortuous mild early sigmoid changes. Manometry shows type 2 achalasia. So again, I put 5 port as usual, and my right and left hand is a robotic port, 8 mm ports with the camera 10 mm, 2 laparoscopic port, one for retraction of the liver, another for retraction of the stomach. So I open the gastrocolic omentum, and then I reach the crest, right pillar of right crest. The same surgery, same techniques. You have seen 2-3 videos of laparoscopic Hellers. This is robotic Hellers. You can see the 3 robotic trocar, camera on either side, working instrument, and 2 laparoscopic port, one for liver retraction, one for retraction of the stomach. So I am sitting in the console. This is the open console, and this robotic system has a forward docking. So I just started peritoneal incision, and more left hand is a fenestrated bipolar grasper, right hand the blue color one is a scissor, monopolar scissor. So I am using the entire mobilization of esophagus with the monopolar scissor only. So I just open up the fat plane between the crest and the fat plane, so that a retroesophageal window is being created, and you can see the camera, and what I am using for previous videos are 4K camera, and here it is only HD camera, but even though you can see HD, the vision is so clear and it is like a magnified view, and this is the post vagus now, and camera control is by the surgeon, I am controlling the camera. I am dividing the phrenoesophageal membrane. You can see I am dividing with the monopolar scissor. We have to see the vagus now before division. Now you can see I just retracting the phrenoesophageal from the esophagus. You can see I turn the scissor. Now you can see the white color phrenoesophageal membrane. That is, the vagus is seen clearly, the anterior vagus, and crest. This is the phrenoesophageal. Crest is also seen very clearly. So without damage the other tissues, I can able to go. And even though it's a HD camera, I could see the very clear view, and during surgery I am seeing a 3D view, and what the close-up view you are seeing, it is more than that when you are seeing the 3D. It will be more close-up focus what I am seeing in 3D than this. So this is the 2D video. So again I am coming on this phrenoesophageal membrane on the left pillar of right crest division. Initially I thought very difficult of esophageal mobilization with monopolar, because laparoscopically I am using only harmonic scalpel. So without harmonic I am not using a monopolar for esophageal mobilization. I thought it is difficult. So once I started doing in robotic Fundo and Heller, so it is plane is so nicely seen, very close up focus. So it is very monopolar is good enough to mobilize the esophagus. Only for a short gastric division of fundal mobilization and short gastric division, I use laparoscopic instruments. My assistant using ligature, that is a vessel sealing device. Otherwise, I use entire mobilization with the monopolar. So this is the attachment between the thoracic aorta and the crest is released. The previous instrument is I changed it to the same thing. Anything can be used with the left hand. This is the Maryland bipolar, and that instrument that is they introduced recently the fenestrated one, but without the bipolar. So that's why I changed to this bipolar instrument. And nowadays they have a fenestrated bipolar. CMR has fenestrated bipolar. This surgery is done maybe I can say around a year or 2 year back. So that time there is no fenestrated with bipolar with the CMR. So I have to mobilize the esophagus carefully from the pleura and the thoracic aorta, because the CT shows it is a tortuosity on the right side and also dilated esophagus. So after doing some dissection on the right side, I came anteriorly. You can see the vagus is also, it's like a bending, no, it's not straight vagus because of the tortuosity of the esophagus. Vagus is also bent, course is irregular course. So bare area of stomach, and again some phrenoesophageal attachment is divided from the left pillar of right kidney, that is inferior phrenic vessel, it is preserved. So always you have to preserve, this is the entire supply of the left hemidiaphragm, so inferior phrenic vessel to be preserved. So again some fibers of the phrenoesophageal is divided. So now the advantage of you can see the tortuous course of the vagus now, because of the tortuous course of the esophagus, the vagus is also the same course. Understanding anatomy is, I feel, very clearly seen in robotic surgery rather than the compare with the laparoscopy, because it is a very close-up focus, and even though it is a HD vision, since I am seeing in a 3D, so I feel it is a very good quality, and the depth is also very 3D good depth and very close-up focus. So from the left pillar I am trying to uh, dissect the esophagus. Normally, if you retract the crest like this, is a plane will be seen. Since it is a dilated, there is no plane. Dilated esophagus plane is not seeing. So anteriorly, I'm just mobilizing it. Any vessel is there, you can coagulate and then retract. So I shifted my liver retractor into the hiatus. So I started separating the pleura from the esophagus. You can see the liver retractor is in the mediastinum now. You can see the pleura now. Monopolar is good enough. You can see it is like almost minimally edited video. I am not using a bipolar. Rarely I am using bipolar, and most of my dissection is with the monopolar scissor only. So our aim is to straighten the esophagus uh, and then do myotomy. So that then only the result is better. And in this case, this type of tortuous esophagus and traction is the one key for complete mobilization of the esophagus. Without traction, it's very difficult because pleura will not separated from the esophagus. You can see the vessel is going. So I coagulate the vessel. So I'm coagulating the vessel. And we have to protect the anterior vagus when you are dissecting on the left. So now that is the anterior vagus. Because the entire hiatus mediastinum is occupied by the esophagus. Even if I retract the crest, I am not able to get the plane. When I am doing a fundoplication, this step will be very easier. When I retract the crest, then nice plane will be seen between the crest and the esophagus. But here it is a dilated one, I couldn't get. Again, I am coming on the anterior side. It is not a simple case, it is a difficult case, but even that is difficult case, I am not feeling finding any difficult when I operate. And with the monopolar, I am just touching the tissue and then separating the tissue is very easily seen. Now, I think I am going to retract, that retractor can shift to the left side, and then I can able to do the dissection. So now again I am coming to the right side now. So now you can see with the retractor, I retract the liver retractor forceps, I retract the crest. Now you can see the pleura is seen clearly. I want this much exposure, I couldn't achieve it before. So now I hold the pleura with my left hand, and then crest is retracted by the liver retractor. So now I am separating the tissue, dividing the tissue, so that the pleura will go away from the esophagus on the left side. Now you can see it is separated. Or we have to put some extra port, laparoscopic port or robotic port, so that it will retract the mediastinum and crucial ligament or the left pillar of right crest. So now it is done on the left side. Now I am coming on the right side. Now it's almost esophagus is straight. Now you can able to appreciate it is a straight esophagus is already achieved. That is the vagus nerve. So that is the anterior vagus nerve. So now I am going for anterior vagus mobilization. Again I am using scissor with the monopolar. Whenever any vessel is there, I can use a bipolar. So already I mentioned clearly, I described with the previous video. When you are separating the anterior vagus from the esophagus, we have to take one layer. See, this is the layer. See, I am taking that layer so that the muscles of esophagus will be bared, will see seen very clearly. The adventitial covering is removed now. You can see the longitudinal muscle fiber clearly. Usually, I do this type laparoscopically using a harmonic scalpel. I never done with the monopolar hook or scissor, but here I am using a monopolar scissor because the vision is so good, and I could see the fiber by fiber, and then the exact plane is very well seen. Sorry, robotically very well seen. So if anyone is using a energy device in robotic surgery, that means they are violating the plane. That's what I observed. Laparoscopically, we are using a energy device like a harmonic scalpel and ligature, and we are happy that there is no bleeding. But actually, we are violating the plane with that energy device. Here, the plane is open up, so that there is no need for any energy device. No, we are in the right plane robotically. So it is very very clear anatomy, and you can enjoy, and then you can do the surgery, and your mind will be happy at the end of the surgery, because we are without touching the patient, we are operating, and you are seeing the different kind of view in a robotic 3D. So it's very good. Nowadays my preference is all upper GI surgeries, robotic is the first choice, then lab, because I'm doing so many years. But even though I feel better robotic surgery with robotically. You can see how much close-up focus I am operating. Each and a very small vessel, but it's seen very big way. Even laparoscopically, this is difficult case, no? Dilated with the ALE sigmoid, so I have to do very carefully. So our aim is to take out the layer, then only this muscle is exposed, so that myotomy will be easier. So now you can see I am not holding the vagus nerve at any time. With my left hand, I am holding the tissue covering the vagus. You can see the vagus nerve I am not holding at any time, so that the function will not be affected. So now I change the instrument. So bipolar on the right side, fenestrated on the left side. It's like a bowel holding, fenestrated. So that my assistant, actually the staff nurse, experienced staff nurse, long time is here, and I'll teach her. So dividing the tissues. She knows the anatomy and then the way of dissection. So once I retract the fundus with my instrument, see clearly he divide all the anterior and posterior attachment and divide the short gastric vessel without any. This can be done with bipolar coagulation and then scissor cutting, but the exposure is little bit less compared with the other place. So that I feel this ligature vessel sealing device is sealing very nicely, because any named vessel, my way of doing is with the energy device. Unnamed vessel you can do coagulation with the bipolar, because if you are doing a lap chole, we are not doing cystic artery coagulation with the bipolar. So that is why named vessel to be coagulated with the energy device or to be clipped and divided. Unnamed vessel means is less than 2 mm. So we can coagulate with the bipolar. So now fundus is mobilized completely. It took only 5 minutes or maximum 10 minutes. So I am doing a suicide maneuver and then I check the adequacy. Again the cyst is holding the stomach. So I am just separating the tissues on the lesser curvature of the stomach, so that my myotomy will come up to the gastric lesser curvature on the gastric side. There is a small fundus attachment on the left side. I am separating it. So that is the vagus now, and some of the fibers is attached. If I remove the fiber, then vagus goes on the left side. So we have to dissect the vagus from the. It started on the left side and then coming to the right side on the lesser curvature side below the OG junction. So entire thing to be mobilized. So now I started myotomy. So you can see all my video I told first thing is separation of longitudinal muscle. That time we use a coagulation, monopolar or bipolar, because longitudinal muscle has a blood supply. Just below the muscle, the blood vessel will be there. So after that, I am using this robotic Maryland forceps to separate the circular muscle fiber. Once you separate the circular muscle fiber from the mucosa, usually I do with 1 to 2 centimeter above the level of OG junction, and the circular muscle does not have any blood vessel. So you can just tear the muscle without any cautery, that is enough. Again I am dividing the longitudinal muscle. You can see I am putting a coagulation amount of bipolar coagulation current, because to separate the longitudinal muscle. When I divide the circular muscle, I do not use energy. Rarely I use energy. Basically, we are telling that between the mucosa and the circular muscle, but it is not exactly mucosa, it is a submucosa. So that is a correct plane. If you go into the submucosa, then the endoscope is there going in a submucosal plane, then they are dividing the muscle. The same way we are entering the submucosal plane, and in submucosal plane you can go to any length. So with the blunt instrument, you can just introduce the instrument between the submucosal plane and the circular muscle, and so it is a mucosa is protected by thin layer, that is called submucosa. So that is the right plane when you are doing a myotomy. I am not changing any steps when I operate on robotic Heller. Same step, no, all this same step, and I very uh, anatomy very clear in robotic surgery. So that is the exposed mucosa, esophageal mucosa. Once in 3 or 4 centimeter distance, there is a vessel will come on the circular muscle fiber that has to be coagulated. So, I went into the mediastinum. So, the my myotomy length will be 12 centimeter. So, 8 to 9 centimeter on the esophageal, and then OG junction, and then gastric myotomy. So, all together it will be around 12 centimeter. So, again I am separating the muscle fiber, so that the entire anterior 180-degree mucosa will be exposed. There is no fear of mucosal injury if you are following the correct step. The curved tip should not be, you can see my instrument, the curved tip is focused upwards, not downwards. That is the first thing. If you keep downwards and then dissect, means you will injure the mucosa. Entire surgery, if you observe, by separating the longitudinal muscle and circular muscle, I use keep curved tip down. Only the longitudinal muscle separation, it will be down. Otherwise, curved tip is in upward. Tip of the curve is in upward fashion. So, now you can see I change to upward direction, and then I am separating the muscle. This is the OG junction. You can see the muscle fiber on the OG junction. It is no need to separate, just pull the muscle, keep the muscle away, both the muscle edge, push it away, so it will be separated. So, now I am holding the fibers of the OG junction. This is the culprit, no? This is the main pathology site I am operating now. So, again I change the tip of my instrument to the to facing upwards, I am operating. So, now we don't leave, should not leave any fiber on the OG junction. That is a very, very important thing. Each and every fiber you see and then divide. So, now I am coming on the gastric side. Usually I come around 2 centimeter. In case of recurrent uh, Heller, redo Heller, I go for gastric myotomy 3 centimeter length from the OG junction. Otherwise 2 centimeter is enough. Normally 2 centimeter is enough. You can see the oblique fibers of the stomach stomach fibers. This is the potential place for injury of the mucosa on the gastric side, because the gastric mucosa is thinner, esophageal mucosa is thicker. So, most of the time mucosal injury will happen on the gastric side. In 3D, we could see the each and every fibers, no. So, the myotomy is better with robotic surgery. Very clear view, each and every fiber we could see very clearly. Now you can see I am holding the fiber, I am separating it. Below that it's a very thin mucosa, but even though I am able to find out the muscle, and then I am taking it. So, once the myotomy is completed, we can go for air leak test and then Toupet, and no need for pushing the Ryle's tube into the stomach, but it's our practice. We are doing it for decompression of the stomach at least for 1 day. So, I'm just asked the anesthetist to pass the Ryle's tube. Usually, when I mobilize the esophagus and myotomy, they keep it in the see, that is the Ryle's tube is already crossed. I just feel the Ryle's tube. They keep it at around 30 centimeter length. Then after that 25 to 30. Then after that they are pushing it inside. So, now I am checking the air leak. I just occlude and then air will be injected. And then so I am not doing air leak test here because I am very confident. The problem is usually they have to keep a head and down and then water to be injected. That means I have to undock undock all the robotic instrument, then only I can change the position of the table. So that's why I just avoid the step, because I was much confident that there is no mucosal injury. So now I am taking the gastric fundus on the right side. So that is the post wall of fundus on the right side. Vagus is pushed to the left side. So now I change the scaling to the fast mode, so that my instrument rotation will be faster than the standard usual manner. So the suturing I used to keep fast scaling, so that the movement will be faster. So I started doing a posterior 180-degree Toupet fundoplication using the polyester suture, that is a Ethibond. Always I take 3 suture with 1 centimeter distance. So 2.5 to 3 centimeter length of Toupet fundoplication I used to do. Like laparoscopy, we keep only one needle holder on the right hand. Left hand, any blunt instrument, Maryland or a fenestrated forceps, we can keep it. This video, it's a real time video. I didn't do any fast fast for during editing. It is just real time. I don't like this make the video speed. So it's a real thing to be shown. Initially, my videos will be little bit slow robotic surgery. So now is robotic time and laparoscopic time is equal, including the docking equal. That means it will be a little bit faster than the robotics laparoscopic surgery. So I am taking on the anterior wall of fundus to the divided muscle on the left side. All steps is same. If you see this laparoscopic surgery and then our previous 4 videos already there, the same step of robotic Hellers. I have done robotic redo Heller also, that also in the pipeline. It will be coming in the another few weeks. We are getting a robotic Heller myotomy done outside, and then it is not done properly, and then I have done robotic redo. So it is done first time also robotic surgery, second time also robotic surgery. Few cases I have done like that, and other case is a laparoscopic failure, and some case open failure also I have done. So that will be coming on the next week's redo surgeries, redo Heller. See, my assistant staff nurse is holding the knot so that it will not be getting loosed, because this suture is tend to loose, unless 3 knot to be made. So it is done. I am checking this vagus. So I am taking my camera inside. I just see whether this crust to be approximated. Actually, it's no need, it is very small only. So you can see the myotomy is going inside the mediastinum. Vagus nerve is crossing, and surgery is complete. Thank you so much.